This is the second talk about ulnar nerve. It deals with the basic neurodiagnostic concepts related to ulnar nerve pathology at the elbow and wrist. It is intended for the neurophysiology fellows at Nicklaus Children's Hospital. This session will be conducted in a question and answer format. The first question is: a patient for ulnar nerve conduction testing should be supine with shoulder abducted 45 degrees and externally rotated. The elbow should be flexed -degrees and the forearm supinated. A 70 to 90, B 40 to 45, C 90 to 125, D 25 to 40. When the arm is extended at the elbow, the ulnar nerve wiggles as it goes through the elbow. Thus, the extended arm is a bad position to electrodiagnostically study the ulnar nerve because the surface distance is shorter than the actual length of the nerve. Thus, conduction velocity will be misleadingly slow. The correct position for ulnar nerve conduction studies is to bend the elbow 70 to 90 degrees. In this position, the surface distance and the nerve length correlates. So the answer to this question is A. In a patient with suspected ulnar nerve pathology at the elbow, all the following nerve conduction studies should be done except A. Ulnar nerve conduction to the abductor digiti quinti, B. Median nerve conduction to the abductor pollicis brevis, C. Median F wave, D. Ulnar nerve conduction to the first dorsal interosseous. 6 studies are routinely used by most labs, by no means by all labs, to evaluate ulnar pathology at the elbow. The first one is ulnar motor nerve conduction study to the abductor digiti quinti with a stimulation at the wrist. The distance between the stimulating cathode and the recording electrode on the muscle belly, that is G1 electrode, should be at least 6 centimeters. Next, stimulation is done below the elbow. Next one above the elbow. And the last one as proximal in the arm as possible in the axilla. The distance between the stimulating wrist electrode and the electrode at the muscle belly is called the distal latency. The section between the wrist cathode and the below the elbow cathode will be labeled in this talk as A. From below the elbow to above the elbow, B. And from above the elbow to the axilla, C. The second test performed as part of the battery of tests for the evaluation of ulnar nerve at the elbow is the F wave. Ulnar F wave is triggered by inverting the polarity of the stimulating device at the wrist and increasing the intensity of the stimulation. The third test is median motor nerve conduction study to the abductor pollicis brevis. This test is performed with a stimulation at just above the wrist and below the elbow, as indicated in this frame. The fourth test is median nerve F wave. The fifth test is ulnar sensory antidromic study recording from the wrist to the fifth finger. And the sixth test is median antidromic study recording from the wrist to the second finger. These tests do not have to be performed in the order that they were presented. The answer to this question is D. Next question. Which of the following is not a criteria for a focal ulnar elbow neuropathy? A. Absolute nerve conduction velocity from the above to the below elbow of less than 50 meters per second. B. An AE to BE segment greater than 10 milliseconds slower than the BE to wrist segment. C. A decrease in compound muscle action potential, negative peak amplitude from stimulation at below the elbow to above the elbow of 9%. D. A significant change in compound muscle action potential configuration triggered from above the elbow site to below the elbow site. Parameters for ulnar nerve motor conduction studies indicative of pathology at the elbow vary from book to book and from lab to lab. The last recommendations by the American Association of Neuromuscular and Electrodiagnostic Medicine I am aware of was published in 2000. In it, the following parameters are listed as indicative of ulnar nerve pathology at the elbow. A conduction velocity throughout the elbow segment, here designated as P, of less than 50 meters per second, or more than 10 milliseconds slower conduction in the elbow segment, here labeled as P, than in the forearm segment, here labeled as A. A drop in after the elbow stimulation compound motor action potential amplitude of more than 20 compared to the before the elbow stimulation compound motor action potential, or a significant morphological change in the configuration of the compound muscle action potential obtained after elbow stimulation to the compound muscle action potential obtained before elbow stimulations are all criteria that have been used to diagnose elbow pathology in patients with ulnar nerve involvement. In Preston's book, it is mentioned as likely representative of true demyelination a drop of amplitude of more than 10 instead of 20 when comparing after elbow to prior elbow potentials, and a drop of 20 to 25 when comparing compound muscle action potential from above the elbow to the compound muscle action potential obtained following wrist stimulation. I find this criteria difficult to understand, starting with the term true demyelination, which implies that there is existence of a false myelinization or forced demyelination. So the answer to this question is C. Next question. In the presence of low ulnar sensory nerve action potential, normal ulnar compound muscle action potential, and distal latencies, and slowing of more than 10 meters per second across the elbow, when compared with elbow to wrist conduction, you should conclude that the patient has an ulnar neuropathy. Dash. A. At the elbow with mixed features. B. At the elbow with pure demyelinating features. C. Without localizing feature. D. At the wrist and elbow. When given multiple parameters to consider, the analysis of each of the parameters should be initially done one at a time, and only after they have been fully analyzed and interpreted in this fashion should they be put together for final analysis and interpretation. So let's start by analyzing low ulnar sensory nerve action potential. Ulnar sensory antidromic study, wrist to fifth finger, was abnormal, as stated in the question. This abnormality indicates loss of sensory axons. As a matter of fact, the amplitude of the sensory nerve action potential generated by distal stimulation and recording is the most sensitive nerve conduction test to detect axonal loss. Next, we should analyze the implication of normal ulnar nerve compound muscle action potential and distal latencies. The ulnar nerve motor compound action potential and distal latency, in this case, was normal, indicating 2 points. The first point is that the normal compound muscle action potential indicates no detectable loss of motor axons in the whole of the ulnar nerve. The second point, that the normal distal latency conduction indicates no demyelination in the segment being studied and further supports the absence of detectable loss of motor conducting fibers in the whole nerve. The last result we must consider individually is the slowing conduction across the elbow. The abnormal conduction across the elbow localizes the pathology to the elbow segment. So now we need to put all this information together into a single explanation that will help us understand what is wrong with the patient. So based on the slowing across the elbow, we can conclude that there is pathology at the site, that is at the elbow. The next step is to determine the type of pathology present at the elbow, which can be demyelinating, axonal loss, or mixed. In this case, the sensory distal study had no findings suggestive of demyelination. Distal latency was normal, but it did show evidence of axonal loss because the amplitude of the potential was low. The motor conduction study showed slowing at the elbow consistent with demyelination, and the normal amplitude with stimulation at the wrist indicated no motor axon lost. Hence, since evidence of both were found, the conclusion is that the pathology at the elbow is mixed. So the answer to this question is A. Next question. In the presence of non-localizable ulnar neuropathy, you should consider doing all of the following except A. Dorsal ulnar cutaneous sensory nerve action potential. B. Sensory or mixed nerve conduction study across the elbow. C. Medial brachial cutaneous sensory nerve action potential. D. Ulnar nerve conduction to first dorsal interosseous. In the presence of suspected but not localizable ulnar neuropathy, 4 additional tests may be helpful. The first one is sensory testing of the dorsal branch of the ulnar nerve, because this branch exits the ulnar nerve prior to the wrist. It provides additional information regarding the sensory components of the ulnar nerve that are not obtained by doing digital studies. The second type of studies that may be helpful are those directed to determine sensory or mixed conduction across the elbow. This can be accomplished by either above and below the elbow stimulation with digit 5 recording as shown in this frame, or by inching the ulnar nerve across the elbow. The third test that can be helpful in the presence of non-localizable ulnar nerve lesion when elbow pathology is suspected is to study ulnar motor conduction recording from the first dorsal interosseous instead of recording from the abductor digiti quinti. The fourth test that may be helpful is median antecubital nerve conduction. This nerve is represented in this figure by the magenta line. The median antecubital nerve arises from the last segment of the medial cord prior to the formation of the ulnar nerve. The cutaneous territories innervated by the medial antebrachial cutaneous nerve is far more extensive than the territory of the medial brachial cutaneous nerve as depicted in this figure. Now let's bring our attention back to the drawing of the arm with the nerve, because I like to point out to you some important recognizable landmarks and structure that we need to identify in order to perform a medial antebrachial cutaneous nerve study. These elements are the median nerve, the biceps tendon, the median epicondyle, the abductor pollicis brevis, and the pisiform. These elements are used to place the electrodes to conduct a median antebrachial cutaneous nerve study. We start by drawing a line from the bicep tendon to the medial epicondyle. Find the middle of this line, which should be located to the medial side of the median nerve, and from that point draw a straight line to the pisiform. Then go 5 centimeters above the elbow line in the axis of the elbow pisiform line and place the cathode of the stimulating electrode at that site. And 14 centimeters below the cathode, in line from the elbow pisiform line, place the G1 recording electrode with the reference electrode 4 centimeters more distal to the same line. The ground is placed between the stimulating and the recording electrodes. So the answer to this question is C. The proper testing would be to the medial antebrachial cutaneous sensory nerve action potential. Next question. The medial antebrachial cutaneous nerve travels away from the ulnar nerve at the mid-arm. A true, B false. The medial forearm sensory nerve is an alternative name for the medial antebrachial cutaneous nerve, the name that we have been using. In the upper arm, the medial antebrachial cutaneous nerve travels with most other upper extremities nerve, keeping the company of the ulnar nerve, the median nerve, the medial brachial cutaneous nerve, the radial nerve, and even the musculocutaneous nerve that at this level transfers the coracobrachial brachialis muscle. The medial antebrachial cutaneous nerve soon departs from the company of the other nerves, traveling towards the anterior medial surface of the arm to innervate a large band of skin extending from the axilla to the wrist. So the answer to this question is A. Next question. Ulnar entrapment at the elbow region usually occurs below the cubital retinaculum. A true, B false. I hope you recall this figure from the first talk about the ulnar nerve. I will use it again to signal the possible zones of entrapment. These zones are the medial intermuscular septum, the arcade of extruders, the tricep tendon at its attachment to the humerus, the retrocondylar groove overlying the cubital retinaculum, the arcade of Osborn, the joining of the two heads of the flexor carpi ulnaris, and a bad anconius epitrochalis, not just its presence. The bottom line is that the site of ulnar involvement at the elbow is anywhere in the elbow region. So the answer to this question is B. It may occur anywhere. Next question. The most common underlying pathophysiology affecting the ulnar nerve at the elbow is A. Conduction failure, B. Synchronized conduction slowing, C. Conduction block, D. Desynchronized conduction slowing. Of the four types of conduction pathologies found at the elbow, the synchronized slowing, conduction slowing, and conduction failure, this later one is the most common encounter at the elbow. With stimulation prior to the site of the injury, no recordable potential will occur when testing sensory fibers. Whereas with distal stimulation, that is distal to the injured site, stimulation also produces no potential. With motor fiber testing, stimulation prior to the injury produces no potential. Motor stimulation after the injury, that is distal to the injury, also fails to produce a potential. This is characteristic of conduction failure. So the answer to this question is A. Next question. Evidence of conduction failure present in a motor nerve conduction study recording from FDI with elbow and wrist stimulations is always an indication of an axonal loss lesion. A true, B false. In a patient with ulnar nerve involvement at the site indicated by the red line corresponding with a long demyelinating patch, we find when recording from FDI following wrist stimulation no compound motor action potential. The same will occur with more proximal stimulation below the elbow and further up above the elbow. Such findings are indicative of conduction failure, which are usually interpreted to be due to axonal loss lesions. But conduction failure, although most often indicates an axonal loss pathology, in a few occasions it is due to a long myelin loss lesion located beyond our ability for stimulation distally to it, as we have seen in this make-believe situation. In addition, a neuromuscular blockage selectively applied to the studied muscle can produce nerve conduction findings consistent with conduction failure. So the answer to this question is false. Next question. Flexion of the distal phalanx of the fifth finger at the distal interphalangeal joint is the best way to activate the A. Flexor carpi lunaris, B. Flexor digitarum profundus ulnar side, C. Flexor digitarum superficialis, D. Abductor digiti quinti. EMG of the flexor carpi lunaris is performed by introducing a needle in the upper third of the forearm on the medial side. Activation is achieved by asking the patient to flex and adduct the hand, as indicated in this picture. EMG of the ulnar component of the flexor digitorum profundus is best performed much in the same way, but the needle is inserted more to the middle of the forearm, and because of the position of the muscle in the forearm is slightly dorsal to the flexor carpi lunaris, the needle is usually inserted more from the dorsal aspect of the forearm, as indicated in this frame. Activation is achieved by asking the patient to flex the distal phalanx of the little finger. EMG of the flexor digitarum superficialis is performed by inserting a needle in the mid-forearm anterior at a mid-distance between the middle of the arm and the ulnar border of the forearm, as you can see indicated in this frame by the number 1/2. Activation is achieved by flexion of the middle phalanx of the fourth finger at the proximal interphalangeal joint. EMG of the abductor digiti quinti is performed by inserting the needle between the pisiform and the head of the fifth metacarpal bone. This insertion is performed about the mid-distance between them, as indicated in this frame. This insertion is performed on the ulnar side, as you can see. Activation is achieved by asking the patient to abduct the little finger. So the answer to this question is B. Next question. The presence of an ulnar nerve lesion in mid-arm sparing the flexor carpi lunaris can be explained based on the fascicular distribution of fibers in the ulnar nerve and the typical evolution of nerve injury. A true, B false. Some patients with ulnar lesions at the arm have deficit reflecting involvement of all ulnar innervated forearm and hand muscles, which I have represented by coloring the fibers to those muscles brown in this figure, while sparing the flexor carpi ulnaris, which I have represented in this figure by using a green line. Two possibilities have been put forward to explain this occurrence. The first possibility is a multifascicular ulnar involvement, such as a lesion as I have represented in this frame can spare the fascicle carrying the flexor carpi ulnaris fibers, either because of the relation between the location of the noxious agent and the flexor carpi ulnaris fascicle within the nerve, or because the flexor carpi ulnaris axons having a thick or thicker perineum surrounding them than all the other fascicles. The second explanation for a lesion above the elbow producing the finding being discussed is related to the evolution of nerve injury. I will, in order to explain this possibility, introduce this diagram. As you can see, worsening indicated by the red arrow is in the y-axis and time is in the x-axis. In addition, in the y-axis, but on the other side, I have represented improvement by drawing a down-going arrow in green. Now I have introduced a representation of the neurons innervated, the most distal muscle tested, in this case the abductor digiti quinti. The muscle is represented by the brown rectangle. Now I am representing the flexor digitorum profundus and the shortest neuron innervating the flexor carpi ulnaris. I have now introduced these elements inside the diagram. Notice that the rectangle representing the muscles are brown. The brown color indicates normalcy in the muscles in this figure. The white arrow that I have just introduced indicates the evolution of the injury. The red line just added across the neurons represents the site of the lesion involving the fibers going towards the three muscles. Such a lesion will first produce signs of denervation in the muscle closest to the injured site, here represented in gray and corresponding in our scheme to the flexor carpi ulnaris. As time goes by, the lesion, if intensive enough, will involve the fibers going for the intermediate muscle, here represented by the flexor digitorum profundus, and we will see evidence of denervation in that muscle. And finally, in the case of continuous deterioration, the last muscle that would be affected in this scheme will be the abductor digiti quinti. On the other hand, if the evolution of the lesion is not so acute and a plateau period occurs during which only two muscles are affected, and this pattern of deficit may persist for a while, and further deterioration may actually occur later, or improvement. Recovery will start with the muscles nearest to the injury. So at this stage, the flexor carpi ulnaris will improve. And if recovery continues, then the flexor digitorum profundus would improve. if recovery starts after all the muscles are involved, represented here by the interrupted line, and after by the solid downgoing arrow, then again the muscles innervated by the nearest fiber to the injury will improve first in this scheme corresponding to those fibers from the flexor carpi ulnaris. Hence, this would be the muscle that would be normal before any other of the two muscles that we have been describing. After, the muscles innervated by the next nearest fiber will improve, in this case the flexor digitorum profundus, and finally the fibers from innervating the abductor digiti quinti will recover, and therefore this muscle will show absence of denervation, because they are the last to recover, because they are the furthest from the lesion. The purpose of this convoluted explanation is to highlight the evolution of muscle involvement that occurs following nerve injury, and the different stages in the evolution of the nerve. As you can see, those muscles that are closest to the injury site will recover first, while those more distally will show signs of denervation for longer. In this case, the first one that will recover will be the flexor carpi ulnaris, and that could explain why at times we find that muscle recovered or working properly while the other more distal muscles are still not working well. So the answer to this question is A, true. Next question. The presence of weakness of all ulnar innervated muscle except for the flexor carpi ulnaris in the absence of an ulnar nerve lesion can be explained based on a brachial plexus lesion, a prebrachial plexus lesion, or a motor neuron pathology. A true, B false. Flexor carpi ulnaris sparing in the absence of ulnar nerve lesion can occur, at least theoretically, with a lesion affecting all ulnar nerve fibers except those fibers innervating the flexor carpi ulnaris proximally to the formation of the ulnar nerve. This can occur at the level of the brachial plexus, at the prebrachial plexus structures, or with motor neuron pathology. So the answer to this question is true. Next question. In the brachial plexus, ulnar fibers innervating the flexor carpi ulnaris can be involved with lesions in all of the following structures except A, medial cord, B, posterior division of the lower trunk, C, lower trunk, D, ventral rami of C8. The fibers for the flexor carpi ulnaris in the brachial plexus can be damaged at the medial cord, the anterior division of the lower trunk, the ventral ramus of C8, and the ventral ramus of T1. So the answer to this question is B. Next question. In the prebrachial plexus nerve bundles, ulnar fibers innervating the flexor carpi ulnaris producing denervation can be involved with lesions in all of the following structures except A, C8 spinal nerve, B, C8 ventral root, C, C8 dorsal root, D, T1 ventral root. Prebrachial plexus lesion that can, at least theoretically, produce flexor carpi ulnaris denervation sparing all other ulnar nerve innervated muscles can be localized to C8 spinal nerve, C8 ventral root and rootlets, T1 spinal nerve, and T1 ventral root and rootlets. So the answer to this question is C. Next question. The presence of weakness of all ulnar innervated muscle except for the flexor carpi ulnaris in the absence of an ulnar nerve lesion can be explained based on the localization of motor neurons within the anterior horn. A true, B false. The explanation given for flexor carpi ulnaris sparing in patients with motor neuron disease relates to the evolution of axonopathies. In cases of axonopathies, that is when either the cell body or the axon transport system is just about to fail supplying the distal most region of the axon, that is prior to any clinical involvement, all muscles innervated by those fibers from those affected nerve prior to significant involvement demonstrate no pathology. With disease progression, the most distal neurons are first affected. Thus, in this case, those corresponding to the most distal muscle, which is the abductor pollicis quincti in our example, will be affected first. Further progression will affect axon traveling in intermediate distance. Again, in the example we are using, it would be those axons innervating the flexum digitarum profundus. Thus, at this stage, only the flexor carpi ulnaris will remain unaffected. With further progression, all muscles will be affected. Thus, an evaluation of the ulnar nerve at the stage pointed by the arrow can produce sparing of the flexor carpi ulnaris muscle. So the answer to this question is B. In patients with suspected elbow pathology, all the following muscles should be EMG to determine the status of the ulnar nerve, except A. First dorsal interosseous, B. Flexor digitorum profundus, C. Second lumbrical, D. Flexor carpi ulnaris. 3 ulnar innervated muscles are usually tested in these situations: the flexor carpi ulnaris, the flexor digitorum profundus to the fifth finger, and either the first dorsal interosseous or the abductor digiti quincti. So the answer to this question is C. Next question. In the presence of ulnar innervated muscle EMG abnormalities, you should test all the following extra muscles except A. Abductor pollicis brevis, B. Extensor indicis proprius, C. Paraspinal muscles, D. Biceps. The following muscles should be tested in the presence of an abnormality in the initial ulnar nerve EMG evaluation: the C8-T1 paraspinal muscles, the extensor indicis proprius, the first dorsal interosseous or the abductor digiti quincti, whichever was not done in the initial evaluation, and also the abductor pollicis brevis. So the answer to this question is D. Next question. Which of the following paraspinal muscles are innervated by the dorsal rami? A. Transversospinalis, B. Erector spinae, C. Interspinals, D. All of the above. This is a representation of C8 spinal segment and prebrachial plexus bundles, as well as showing the ventral and the dorsal rami. I am now indicating the dorsal ramus. It is from this ramus that the paraspinal muscles are innervated. This is a representation of the paraspinal muscles, all of which are innervated by the dorsal rami. The paraspinal muscles can be divided in two groups, the transverso spinalis and the erector spinalis. The transverso spinalis include the rotators, multifundus, and semispinalis. They are deep muscles, and doing EMG of these muscles can be very painful. The erector spinae includes the spinalis, the longissimus, and the iliocostalis. Here I have incorporated a higher cut of the same muscles in bony structures to show the position of the interspinalis muscles. These muscles go from one spinal process to the next. So the answer to this question is D. Next question. The interspinalis is a good muscle to do paraspinal EMG. A true, B false. In this frame, the dorsal rami is towards you. The aim of the paraspinal EMG is to test a specific dorsal ramus, thus finding a muscle innervated from a single spinal segment, that is a muscle with monosegmental innervation, is optimal. I have now included a view of the spinal bodies with the corresponding deep paraspinal muscles and the interspinalis with the corresponding dorsal ramus innervation by their side. As you recall from our answer to the last question, the interspinalis go from one spinal process to the next. Some authors suggest that this is a good muscle to test when looking for monosegmental paraspinal muscles. This is probably true based on the fact that the interspinalis are the last muscle innervated by the dorsal ramus in each segment. One issue regarding EMG of the paraspinal muscle is the frequency of fibrillation in asymptomatic controls. The incidence of fibrillation has been reported as high as 15% in young adults and in up to 43% in the geriatric population. So the answer to this question is A. Next question. Please take a look at this figure and try to answer. The question is, this study shows unequivocal evidence of conduction block. A. True, B. False. The presence of a dip prior to the negative potential in a compound muscle action potential indicates one of three things. The first possibility is that the electrode is in the correct muscle but not at the motor point of the muscle. The second possibility is that the electrode is not in the correct muscle and is therefore capturing a potential moving towards the electrode from another muscle. The third possibility is that the potential is contaminated by activity captured by the reference electrode, which is also labeled G2. The other features of this recording is the drop in amplitude of the compound muscle action potential when comparing the amplitude of the distal stimulation trigger potential to the amplitude of the proximal stimulated compound muscle action potential. The implication is that more functional axons, as it relates to the tested muscles, are presented proximally than distally. This phenomenon can result from a conduction block or the distal arrival of previously misdirected fibers going to a given muscle as it occurs with anomalous innervation. So the answer to this question is B. Next question. Which of the following factors make ulnar nerve evaluation less reliable? A. A distance between the above and below elbow stimulation site of 4 centimeters. B. Low temperature. C. High body mass. D. All of the above. One of the factors that makes ulnar or any other nerve electrodiagnostic evaluation less reliable is called temperature. Low temperature increases amplitude of the potentials, but it slows down conduction. Increased distance from the stimulator to the nerve also produces problems by artificially slowing the appearance of the potential to be interpreted, especially when compared with very thin controls. A third factor that interferes with nerve conduction results is a short distance from the stimulator to the G1 electrode. 3 centimeters is too short of a distance for reliable interpretation of nerve conduction. 6 centimeters is acceptable, and 10 centimeters is desirable. So the answer to this question is D. Next question. What test would you order based on this study? A. MRI. B. CT scan. C. X-ray. D. Ultrasound. Please take a few minutes to look at this figure and choose the correct answer. Here you can see that the most distal stimulation produced a normal potential. So did the one above, the next one, and the next one. But at label 3, the takeoff of the potential is delayed and the morphology changed. The response to stimulation at level 2 is similar to that response obtained by stimulating level 3, and so is the potential after stimulating level 1. So a delay coinciding with a morphological change was present when going from 3 to 4. Here you can see them all stacked for better appreciation. In the presence of this finding, the study of choice is ultrasound. At the site of the block, as you can see in this frame, the nerve is swollen. Below, the nerve is much thinner. So the answer to this question is D. Next question. Anconeus epitrochlearis is a common cause of ulnar nerve entrapment at the elbow. A true, B false. This figure is from an AANEM paper listing the places and causes of ulnar nerve entrapment. One of the sites listed is the Anconeus epitrochlearis. Hypertrophic Anconeus epitrochlearis can produce ulnar neuropathy at the elbow. It is certainly not a frequent cause. but it is relevant because it is treatable. Notice the color difference of the segment of the ulnar nerve under the muscle before the muscle was cut. It is important to realize that not just the mere existence of this muscle in a patient can be blamed for ulnar neuropathy at the elbow, since many individuals with this muscle do not have ulnar neuropathy at the elbow. So the answer to this question is B. Next question. The purpose of axillary stimulation in ulnar nerve studies is to assure inclusion of the dash site. A. Osborn fascia. B. Ligament of Struder. C. Arcade of Struder. D. Elbow retinaculum. When performing an ulnar nerve motor conduction study, it is advisable to stimulate as proximal as possible in the arm, if possible in the axilla. This is so in order not to miss ulnar nerve entrapments at the medial intermuscular septum and at the arcade of Struder. Remember that arcade of Struder entraps the ulnar nerve, whereas the ligament of Struder entraps the median nerve. So the answer to this question is C. Next question. The G2 for first dorsal interosseous manus recording should be placed distally over the dash joint. A. Index finger PIP. B. Index finger DIP. C. Thumb IP. D. Ring finger PIP. When performing an ulnar nerve motor study using the first dorsal interosseous, placing G2 electrode on the index finger may produce an action potential with a dip prior to the negative wave. This dip goes away by placing the G2 electrode on the thumb. This is advisable and desirable because such potential can be more accurately read than when a dip is present before the negative wave. So the answer to this question is C. Next question. In the presence of the findings in this frame, you can conclude that the ulnar nerve pathology is above the wrist. A true, B false. The ulnar sensory latency obtained by stimulation of the dorsal ulnar cutaneous nerve in this case was abnormal in the affected side when compared with the opposite and normal side. So was the ulnar sensory distal latency to the fifth digit. Such pattern indicates ulnar nerve involvement above the wrist. So the answer to this question is A. Next question. In the presence of these findings, you can conclude that the ulnar nerve is involved at the wrist. A true, B false. In this case, the sensory ulnar study to the fifth digit is abnormal, whereas the dorsal ulnar cutaneous nerve study was normal. The most accurate interpretation in this pattern is to conclude that the findings suggest ulnar nerve involvement at the wrist, but to add that pathology at the elbow cannot be excluded. The explanation for this conclusion that is adding that elbow involvement cannot be excluded to the initial interpretation arising from the fact that fibers for the dorsal cutaneous nerve depart or may depart from the ulnar nerve trunk prior to it traveling through the elbow segment. In cases of trunk involvement at the level of the elbow, therefore, the dorsocutaneous fibers may be spared. And in some individuals, the dorsal ulnar region of the hand is innervated by a branch of the radial nerve. So there are two reasons for it. One is that the fibers for the dorsocutaneous nerve may leave the trunk of the ulnar nerve before it reaches the elbow and continues separately in the forearm. And the second reason is that that area may be innervated by a branch of the radial nerve, as you can see in this frame. So the answer to this question is B. Next question. In the presence of these findings, you can conclude that there is no ulnar nerve involvement. In this situation, when both tests are normal, the interpretation should be restricted to the test performed. So it would be appropriate to say that no electrodiagnostic evidence of axonal neuropathy affected the ulnar sensory fibers is present. But a demyelinating lesion above the forearm is possible. So the answer to this question is B. Next question. Radial nerve cutaneous innervation of the ulnar side of the hand occurs in about -% of normal people. A2, B15, C40, D5. The ulnar dorsal region of the hand is usually innervated by the ulnar nerve. So stimulation of the ulnar nerve in the distal forearm produces a potential. But at times, the ulnar dorsal region of the hand is innervated by the radial nerve, as we just mentioned in the prior answer. In those cases, stimulation above the wrist on the ulnar distal forearm fail to produce a potential. This anomalous innervation pattern, that is innervation of the dorsal ulnar side of the hand by the radial nerve, has been reported in 60% of patients in one study. So the answer to this question is B. Next question. In a patient with clinical suspicion of ulnar nerve pathology at the wrist, all the following studies should be done, except A. Ulnar nerve conduction to the abductor digiti quinti, B. Medial nerve conduction to the abductor pollicis brevis, C. Inching across the wrist, D. Ulnar nerve conduction to first dorsal interosseous. Most authors consider that 9 studies should be done in patients suspected of ulnar nerve involvement at the wrist. The first study is motor ulnar nerve study recording from the abductor digiti quinti. This study should be done stimulating at the wrist, about 6 to 8 centimeters from the recording electrode, as you know. Next stimulation should be done below the elbow. Next above the elbow. And the last one at about the axilla. The second test should be ulnar motor study to the first dorsal interosseous. The third test should be motor study to the first dorsal interosseous going 3 centimeters above the wrist and 4 centimeters below the wrist. The fourth study should be ulnar nerve F wave. The fifth study, median nerve motor conduction study recording from the abductor pollicis brevis and stimulating above the wrist and below the elbow. The sixth study, median F wave. The seventh study, ulnar nerve antidromic sensory study to the 5th digit. The eighth study, median sensory to the 4th digit. And the ninth study, sensory nerve conduction evaluation of the dorsal cutaneous nerve. These studies that I have just mentioned do not need to follow the numerical order I have just stated as long as they are done. So the answer to this question is C. Next question. The most sensitive and specific test for localizing ulnar nerve injury at the wrist is wrist and palmar to FDI study. A true, B false. Most authors I have read consider that wrist and palm to FDI is the most sensitive and specific test to detect ulnar nerve pathology at the wrist. This is an example of the study obtained in a patient with ulnar nerve pathology at the wrist. The drop in amplitude is more than 20%. Distal stimulation after the wrist was 20% taller than the proximal stimulation prior to the wrist. And the second information from this study is that the conduction velocity through the palm to wrist segment in this case was 36 meters per second. The lower limits of normal being 37 meters per second. So the answer to this question is A. Next question. Which of the following ulnar muscles is being monitored during lumbrical interosseous comparison study? A. First lumbrical. B. First palmar interosseous. C. First dorsal interosseous. D. Third lumbrical. The lumbrical interosseous comparison study records from the palm of the hand just below between the second and the third fingers after stimulating the ulnar and the median nerve proximal to the wrist. In this study, the location of the electrode monitoring the activity are the second lumbrical, a median nerve innervated muscle, and the first palmar interosseous and ulnar innervated muscle. A stimulation of the median nerve usually produces a larger potential than a stimulation of the ulnar nerve. This is because the lumbricals are closer to the surface than the palmar interossei. But if the electrodes are equidistantly placed, the latency should be about equal. So the answer to this question is B. Next question. The most common cause of ulnar neuropathy at Guyon's canal is A. Fracture of the pisiform. B. Hypertrophy of the palmaris longus. C. Ganglion cyst. D. Arthritis. This is a photograph of an ulnar nerve being compressed by an anomalous muscle, considered by the author to be an anomalous palmary muscle. This occurrence is quite rare, but since it is a treatable condition, it should always be considered. Far more common cause, as a matter of fact, the most common cause of ulnar neuropathy at the wrist is present in this MRI. And here, pointed by the arrow, is that cause, which is a ganglion cyst. A ganglion cyst, as I just mentioned, is the most common cause of ulnar nerve compression at the Guyon's canal. So the answer to this question is C. Next question. Which of the following tests would not help distinguish a peripheral neuropathy from an ulnar nerve entrapment at the wrist? A. Lumbrical interosseous distal latency. B. Inching across the wrist. C. Antidromic ulnar and median to the fourth digit. D. Palmar orthodromic median and ulnar mixed nerve study. The distinction between upper extremity neuropathy and ulnar or median nerve entrapment at the wrist is based on finding equal involvement of the ulnar and median nerve bilaterally in cases of peripheral neuropathy, or of isolated involvement of one or the other nerve in cases of entrapment. Those tests that compare the ulnar and the median nerve on equal footing are most appropriate for this purpose. This figure demonstrates ulnar nerve wrist entrapment. Notice the latency difference between the median, which is normal, and the ulnar, which is abnormal. Other useful tests for the same purpose are comparison studies between antidromic ulnar to the fourth digit and median to the second digit, as long as the distance is kept constant. A third test for the same purpose is using ulnar and median stimulation recording from the fourth digit, since sensory innervation of this digit is shared by the median and the ulnar nerve. The fourth study that can be used to compare median and ulnar conduction is the Palmar orthodromic median and ulnar nerve studies. You can see the placement of the electrodes in this frame. Notice the location of the stimulator at the wrist. So the answer to this question is B. Next question. In a patient with suspected ulnar nerve wrist entrapment, all the following muscles should be EMG except A. FDI, B. Flexor digitorum profundus, C. ADDM, D. Flexor carpi ulnaris. In cases of suspected ulnar nerve wrist entrapment, four muscles are often studied. They are the flexor carpi ulnaris, the flexor digitorum profundus to the fifth finger, the abductor digiti quinti, and the first dorsal interosseous. So the answer to this question is C. Next question. In the presence of ulnar innervated muscle EMG abnormalities found during the initial evaluation for ulnar neuropathy at the wrist, you should test all the following muscles except A. Abductus pollicis brevis, B. Extensor indicis proprius, C. Paraspinal muscles, D. Biceps. Once ulnar nerve EMG pathology is found, the workup should be extended to include C8 and T1 paraspinals, the extensor indicis proprius, the flexor pollicis longus, and the abductor pollicis brevis. So the answer to this question is D. Next question. What is the purpose of testing the extensor indicis proprius during ulnar nerve evaluation? A. To survey the lower trunk. B. To survey the anterior division of the lower trunk. C. To survey the medial cord. D. To survey the dorsal C8 and T1 rami. The extensor indicis proprius arises from C6, C7, and C8 spinal cord segments and travels in the trunks and their posterior division to the posterior cord. Ulnar nerve fibers arise from C8 and T1 spinal segments, travel in the lower trunk, exiting it through the anterior division towards the medial cord. Thus, the extensor indicis and the ulnar muscles share C8 spinal segment, C8 roots, C8 spinal nerves, the ventral ramus of C8, and the lower trunk. Thus, involvement of the extensor indicis suggests deletion in any of these shared structures. So the answer to this question is A. Next question. In a patient with motor and sensory deficit in the distribution of the ulnar nerve, the presence of normal digital and dorsal sensory nerve conduction is likely to indicate involvement of A. C8 dorsal root, B. C8 spinal nerve, C. T1 dorsal root, D. C8 ventral ramus. This figure labels the pre-brachial plexus structures. Now I have placed the star in the spinal ganglion. I have done this to indicate the location of the neuronal bodies from where sensory fibers arise. A lesion proximal to these neurons will produce sensory deficit but sensory nerve conduction, since it tests the continuity of the fibers from the body of the neurons to the tested site, will be normal. Regarding the segment involved, we must remember that all sensory information carried by the ulnar nerve goes through the C8 spinal ganglion. So the answer to this question is A. Next question. A patient had an accident 2 months prior to visiting you. He complains of right hand weakness and numbness and tingling in the 4th and 5th fingers. Nerve conduction shows desynchronized slowing over the elbow. EMG is normal. The electrodiagnostic findings explain the presence of A. Numbness and tingling, B. Numbness and weakness, C. Numbness, tingling, and weakness, D. Numbness. As you recall, the basic nerve conduction pathologies that can be found in the ulnar nerve, at the elbow, and elsewhere are summarized in this figure. They include conduction failure, conduction block, synchronized slowing, and desynchronized slowing. Each of these pathologies produce a relatively distinct motor and sensory clinical manifestation. Conduction block and conduction failure produces weakness and anesthesia in the territory supplied by the affected fibers. Desynchronized slowing produces numbness but no weakness. Synchronized slowing produces neither weakness nor numbness. Nerve irritation, as it happens when your leg goes to sleep because of being placed in a bad position, usually against the border of a chair, produces weakness and tingling, but I am not aware that neurodiagnostic changes have been documented because, as it is so short-lived, no testing is ever done. So the answer to this question is D. Next question. 1 day after elbow trauma, in a patient with weak ulnar innervated hand muscles, you find conduction block by comparing before and after elbow stimulation to abductor digiti, quinti, and first dorsal interosseous. The prognosis for recovery is good. A true, B false. The myelinating lesions have good prognosis. They tend to recover in 3 months or less. Axonal loss lesions tend to have poor prognosis, but the degree of badness varies. When the endoneurium is preserved, axonal growth at a rate of 1 millimeter per day offers some hope of recovery without any intervention. When the endoneurium is not preserved, the chances for recovery are minimal because in addition to the axonal growth that has to take place, axons have to slip in the right conduit. A motor axon getting into a sensory conduit means death for the motor axon, and judging by the frequency of this phenomena, the axon's GPS system, which stands for Global Positioning System, appears not to work too well in most instances. The distinction between preserved and not preserved endoneurium cannot be made based on electrodiagnostic testing. Thus, we have to rely on diagnosing axonal loss or myelin loss pathology to prognosticate the outcome of a nerve lesion. And this prognostication will depend on timing, as I hope you are aware. So, as in the vignette in this question, clinically we cannot tell if we are dealing with an axonal loss or a myelin loss lesions, since they both present with weakness. Conduction studies in sensory and motor nerves, when done on the day of the injury, demonstrated after proximal stimulation no action potential, and after distal stimulation normal potentials. These findings, as we previously mentioned, need to be judged in relation to time. Prior to the injury, the timing of the injury being marked by the thunder in the x-axis, all 4 studies are supposed to be normal. On the day of the lesion, that is on the day of the injury and the day after, proximal stimulation produced no potentials and distal stimulation produced normal potential, as we previously mentioned. This pattern does not help distinguish axonal from myelin loss lesions, since one day after an injury, both types of injury will have the same electrodiagnostic correlate. So the answer to this question is B. Thank you very much for your attention.